We're hosting this press conference today to talk about modelling work that's being done by modellers around Australia, led from the Doherty Institute and University of Melbourne. And just by way of introduction, I'm sure you all know that modelling is a really important part of pandemic preparedness. Our modellers, particularly Jody and James, have been thinking about this for years in the context of flu. It's really important in how it informing our planning, but doesn't predict the future. So the Doherty, together with many colleagues around Australia, have been working really tirelessly since the first reports of this coronavirus outbreak to provide modelling to the Commonwealth Government so that we as a nation could be in the best position possible to respond to COVID-19. And I personally think that they've done exactly that. So we've got two of our modellers here today, Professor Jody McFernan. Jody's the Director of Doherty Epidemiology. She's a public health physician and epidemiologist. She's got extensive experience of working with government on pandemic preparedness, particularly focused on influenza. And it's also a great pleasure to have Professor James McCaw. James is Professor of Mathematical Biology and an infectious diseases epidemiologist based at the University of Melbourne. He's an infectious diseases modeller, trained in physics and mathematics, and like Jody, has a really long history of working on pandemic preparedness. I'm going to ask Jody to say a few words about the work that was released today. Then James will say a few words, and then Kath will field questions to either Jody or James, and we plan to finish at 4 o'clock. So welcome again, and I'll hand over to Jody now. Over to you, Jody.
Thanks, Sharon. So just to reiterate what Sharon said, the work that we've done for government in recent months has come from a long experience of planning for pandemic influenza. And so we have a long history of preparedness work in collaboration and consultation with government. And really those models have been repurposed to help to inform the new COVID-19 response plan, which is based on a lot of our thinking about pandemic influenza. It really started our process of modelling for preparedness, started with information from Wuhan early in the epidemic, and it was very clear there that this disease was well beyond our experience of influenza pandemic preparedness. What we were seeing in terms of the rate of growth and early indicators of severity were really very marked, and based on that, we've since seen similar experiences in Europe, in the UK and in the US. So it's been terrible to see those epidemics unfold, but also to confirm our early understanding. And when we went up with our models early on, informed by dialogue with international colleagues, it was very hard to comprehend this extent of severity, but our government believed us and has been engaged in active preparedness and response for this virus since then. A lot of that early modelling helped to inform early border measures, which were stringent in Australia, much more so than in other parts of the world, and informed our management of repatriated Australians from high-risk settings. And at that time, some would have criticised the government for overreacting, but they believed that this was necessary in the face of the challenge that was ahead of us. So the particular piece of evidence that has been released today is our repurposed preparedness models that think about the impact of a pandemic on the healthcare system. And that model thinks about patient flows through the sector. And while a lot of attention's been focused on intensive care requirements, we also think about other parts of the sector that need to be preserved and to be strengthened to be ready for a response. The model is clearly very theoretical, and you've heard that word a lot today. It looks at a theoretical epidemic that occurs uniformly across the country. There's not really much about it that reproduces what we've already seen, but the purpose of it is to allow estimation of the impact of different types of measures and to give qualitative understanding of the sorts of things that are going to be needed to control disease spread, even where lots of things remain highly uncertain. And we explore a lot of uncertainty around the proportion of cases that need admitting to hospital and other things where evidence is still really emerging internationally. And we've based our current models on our best understanding of aggregated information from international settings. It was clear very early that unmitigated epidemics would be well beyond any high-income healthcare country's system capacity. So we knew that that was going to be real, and the model informed the critical importance of public health response measures like case isolation and contact tracing, which have been and will continue to be a cornerstone of the Australian public health response. And that capacity has been dramatically expanded in the past couple of months. The model allowed time with the preparedness and the time that had been bought with early measures to build up health sector capacity, build up public health capacity, but also it was clear that other measures would be needed to further control the spread of this disease. And so Australia, with all other countries, has implemented measures that would not have been considered many months ago. There is not a single pandemic plan globally that talks about lockdown as a control measure. We still are uncertain about the actual contributions of different measures that have been implemented in different settings and their contribution to reducing spread, things like school closure and workplace closure. People are trying to unpick these from observations in Europe, but it's still very unclear. So what we have in the model very theoretically thought about social distancing as an impact on a reduction in spread, and we're now closely observing what's happening in Australia to understand what our measures are doing. We obviously are retaining intense attention on countries who are ahead of us in this epidemic and who've implemented these measures. And the next step, obviously importantly, and what was discussed today, is to understand how the measures Australia has implemented to maintain control have helped us, but also from this position of relative control to identify our next steps. Thanks.
Great, thank you, Jodie. James, over to you.
Thanks, Sharon. So I'm going to build on Jodie's comments and just explain a little bit more about how she and I and the Australian-wide infectious disease modelling team have been contributing modelling-based evidence into the government's decision-making process. So the work released today is really but one part of the contribution we've made to the Commonwealth's planning and response. And I'd just like to emphasise that it's work led by the Doherty, contributed by many people across University of Melbourne and across at least 4 or 5 other institutions around Australia, well beyond the key author list that you see. So our modelling based expertise, which is broader than the one model that you've seen today, has provided perspective and advice on many of the key deliberations held through government, and we've presented that through our advice on and membership of the AHPPC. And this is typical of most scientific research fields. So in our research field of disease modelling and mathematical epidemiology, we draw on multiple sources of information to provide the best advice. And some of that information is the in-house modelling that is being released today. But of course, there's work being done by other scientific groups across Australia, other scientific groups all around the world, and we've been drawing on that to help guide our advice to government. So Jodie and I are members of both international and local working groups. And we've been sharing since mid-January our insights about this rapidly changing situation, and which is obviously highly volatile. And so we have been providing advice on other sorts of measures like social distancing, school closures, and all of those things, primarily based on extensive reviews of the literature. And then we fold some of that into the models you see today. I just want to check my notes. So where to now, I think, is really the key point. And you saw that in the Prime Minister and Chief Medical Officer's presentations and press conference today. So where are we going? Well, Australia has acted sufficiently early, based in part on the work that we've provided and that we've fed into, based on international experience. And I think we're really in a very lucky position where we can think about the next steps and the very challenging questions ahead, but from a position of relative calm as opposed to crisis. We don't have an overwhelmed hospital system yet, and we may well never have one if we continue to base our responses on the best available evidence. But of course, everything there is very uncertain. So yeah, the next few weeks are absolutely crucial. We will see inevitably, with the increased caseload from the last few weeks, inevitably we are going to see an increase in hospitalizations, admissions to ICU and deaths. And I think it's really important at this time to realise that that wave of infections and hospitalizations will be driven by the past cases from the last few weeks. And so that increase is inevitable, and it doesn't mean that there's a loss of control. That's something that is more nuanced and needs to be worked through by analysis of Australian data, which is now underway and going forward. So I think I will leave it there, just to say we're now in this transition from scenario analyses to data science-driven situational awareness in Australia. Thanks.
Great, thank you, James. I'm going to hand over to Kath, who'll field the questions. Over to you, Kath.
Thanks, Sharon. Hi, everyone. For those who don't know me, I'm Catherine Somerville, the Media and Comms Officer at the Doherty Institute. You'll see at the bottom, and some people already have, raise your hand if you would like to ask a question, and we will go ahead and address that. Diane Lewis, please go ahead.
Diane, you're on mute, I think, so you just need to unmute yourself.
Sorry, I'm speaking, I guess, asking a question for Cosmos at the moment. So I just wanted to know whether you could tell me, I couldn't see from the paper, how many people does this model say would have died had no public health interventions such as social distancing been put in place?
So I can answer that. The model doesn't calculate the number of deaths that we would see. And that's very deliberate. Even our estimates of healthcare requirement and healthcare capacity and the need for intensive care and other things are based on really findings at the moment from countries where health systems are largely overwhelmed. We have some estimates of death rates outside hospital and death rates inside hospital, but clearly the ability to be able to provide high quality care is going to be very important, and that's one of the reasons for suppressing the growth and making sure it remains within health sector capacity. So we've chosen not to comment on deaths at this time because the objective of this is to maintain the ability to access high quality care. And obviously over the course of the epidemic, we're also hoping that other advances will be made in better medical treatments and therapies. So we are interested in how to maintain the health system, but deaths have not been a focus of our work. Thank you.
Norman Swan.
Hi, so just two questions really. One is the slides shown by the CMO earlier today at the press conference were a little different from other modelers internationally on the effects of the interventions. And the CMO implied at the press conference that school closure wasn't modelled, and he was interrupted by the Prime Minister on that. Now, why, if that's true, why didn't you, when the Imperial College modellers did show that it had a significant effect? And my second question is, the papers you just released are clearly based very early in the epidemic. They're kind of, it's old data, albeit old is a relative term in the current environment. Now that you have your model, and that's the middle paper, so you clearly got your model, it's pretty straightforward to plug in Australian data. You must have already, and what have you found?
So thanks for the question, Norman. So on the schools, this is what I said in the first part. The advice we've provided to government we have provided a literature review based and modelling literature review based advice to the government around school closures. And then there's been a long deliberation that goes well beyond modelling to come to the position that the government has. And I won't say anything more about that, except to say that as a modelling community, and Australia has a well-renowned or well-respected internationally modelling community, but we are small, and so where we have focused our attention in our own internal work has been what you see in front of you, and then we have been reviewing very carefully work like what you've referred to from Imperial and many other sources, and fed that into the decision-making process on schools. And within this model, we wrap all of those things up in transmission reduction due to social distancing. I think there are good scientific reasons to not have one model that does absolutely everything. You know, the other models you've referred to, which have some of those in, don't necessarily have some of the nuanced issues around where patients might flow that this work contributes. So that's the answer to the first part. The second part about where things are going is indeed you're correct. We now, as we will be able to estimate the epidemic trajectory, which we are in the process of doing, and you heard today about what the plans might be for how that information is communicated by the government. We are looking at those epidemic trajectories. We're feeding that data with the age structures and our emerging understanding of the Australian experience into these sorts of models to make real week in, week out projections of likely burden on our hospital system so that it can be managed as effectively as possible. So I hope that answers the question.
Well, just one supplementary, sorry, Jeff, on that, which is that now that you know from your model what the effect of social distancing is, you know what it is of isolation and quarantining, what's effective, and presumably you could plug in school closure without wanting to labour the point of school closure, just leaving that hanging there. You surely can take the current community transmission graph and model it in terms of effect of those things, and do it in a matter of minutes or hours, not weeks, as suggested by the Prime Minister.
Can I speak to that? I want to speak to the school closure question, Norman, because I think it's very important. I think there's a great tendency to misrepresent model publications sometimes and to assume that input assumptions in models, like here is the proportional effect of school closure, here is the proportional effect of other measures, to take those input assumptions, which are assumptions, and to think that they actually represent an insight or a reality. So, you know, we all understand what Neil Ferguson did, and it was perfectly appropriate to show a model thinking about what if you had multiple layers of interventions and wouldn't they work better in concert? And that's a very logical thing to think, but we shouldn't then take away from that paper that it has shown us what the impact of those measures really is. Neil Ferguson's team at Imperial have been leading a Europe-wide study. You've probably seen some of the preliminary results, trying to disentangle the impacts of a whole range of measures that have been implemented across many countries in Europe, all the way through to lockdown, and showing that, yes, overall doing something makes a difference, but even lockdown, the estimates for the impact of lockdown, you know, sit at around 50%, ranging anywhere from 10 to 90%. And none of the other measures can actually be disentangled because they've been implemented in rapid succession or often concurrently. And so we need to keep watching, we need to keep looking, we need to keep learning. But, you know, I could overlay any number of curves on a model and it would show that things do better and better together. But we actually don't know how well school closure works. And the role of children as transmitters in this epidemic remains very uncertain. So, you know, I think it's a danger to generate too many models in a scenario phase of such high specificity when actually we don't have the evidence to underpin those kinds of impacts. Thanks.
Okay, so we'll move on. Just a reminder, if you would like to ask a question, to raise your virtual hand, and you do that at the bottom of your Zoom screen. Diane, you have another question?
Yes, I do. I was just wondering, there's been some other modelling done in Australia. For example, Mikhail Prokopenko from the University of Sydney has run an agent-based model that shows that we are roughly at the peak, probably, of the epidemic curve at the moment, and by somewhere around July we should be getting close to no new cases of coronavirus popping up. I mean, provided there's no, you know, cruise ships disembarking or anything like that. And so I was just wondering whether you could sort of tell us about how your model differs from that model that Mikhail Prokopenko, apologies, has done, and whether some of that information is available from your model about when this is going to peter out if we continue social distancing.
So I think Jodie and I are playing tag team here, so I'll start answering, and then if she can fill in more if she has some other things to add. So within the Australian community, again, we have been drawing on all of the information that is available, as I think scientists should. And so that work, well, there's been two parts, but the early work that they did has been discussed, and its insights, which are broadly consistent around improvement in outcomes based on layered layered approaches, layered interventions, has been part of the work that we have drawn on to feed into that government decision-making process. So that work has had a positive contribution. And on the sort of more technical side of it, the work we've done is using mathematical equations that are a key part of a lot of mathematical epidemiology and infectious disease modelling. And then a lot of disease modelling is also done in the way they do it, which is more computational. So it's come from computer science rather than applied mathematics backgrounds. These two, we don't have time to go into it in a press conference like this, but these two approaches to modelling have both their strengths and weaknesses, and I think best policy outcomes or advice often comes from looking at both very detailed models like theirs and then more conceptual and theoretical models like the one we've used here. These things play into off each other very helpfully. They both have pros and cons, which is a well understood feature of the literature. In terms of where their model shows what's happening now, we agree that given the control measures we have in place at the moment, we can see in the data that it looks like the curve is flattening and flattening strongly. If we maintain the level of interventions that we have today ongoing, you would expect to see a further decline in cases. There's fewer importations from returning travellers or returning Australians or otherwise. And it looks like community transmission is continuing to be well suppressed. So in that sense, you would say that it looks from a case infection point of view that the peak might have almost passed or is passing, and that then we will see a surge in hospitalizations in the coming week, and then that would die away. But of course, we know that our population is still largely susceptible, and so if we sort of relaxed and went back to normal, we would see a rapid and explosive resurgence in epidemic activity that would be predicted in the same way from our sort of approach to the modelling as from their approach. Both are going to give that same global type of picture going forward if we all went back to normal.
Great, thank you.
Could I just ask a follow-up to that question? I was wondering then, I mean, given that you've got this Australia-wide group of experts doing the modelling, why would you only use equation-based modelling and not agent-based modelling as well, given that, you know, no model's perfect, but if you've got more models that converge on the same answer, then you've got greater confidence?
Well, I guess that's what we're doing. We work. We've been reading those papers. We're bringing them into our evidence synthesis and feeding that information in within our sort of tight little sort of group that we're working on. We've got our limited capacity and we've got our skill sets, and we've developed our models, and then our overall advice to government is based on a range of different modelling work, including that. Jodie might be able to say more. I mean,
I'll just say models need to be fit for purpose of the question. So our model is a clinical care pathways model that's there to assess the impact on the health sector. And that's a model, as I say, that we developed in the preparedness phase. So within that model, there are many capabilities that aren't in the agent-based model, even though it is more granular in other ways. And we also importantly have the capacity to implement quarantine and isolation measures in the model, which are not implemented in the Propenco model. So there are, you know, we build, a model is a tool, and there could be many, many models for the same disease, but you build them to answer a specific set of questions. And with the questions addressed, that's what this model was used for.
That's right. And good advice to policy relies on having all of those different bits come together, which is what we've been doing.
Okay, Kirsten Lawson, can you please go ahead and ask your question? Kirsten, are you there? All right, we might move on. Anna Henderson, can you please go ahead?
Yes, thank you. Can you hear me?
Yes.
Look, I wanted to ask when the bulk of this modelling detail, like not perhaps the most recent stuff, but the bulk of it was actually provided to public health officials. And secondary to that, what is the next big step in what you're seeing that would make the next difference that Australia is yet to take? It may not take it, but in terms of the modelling, what's the next step in changing the way we operate that would have an impact on spread?
Jodie, would you like to address
Yeah,
that?
I will answer that. I'm just thinking about that big question. So you know, as I said, these are, so we've talked about the fact that these scenario models, and Norman says the data informing them is old. In fact, the estimates of the health sector use are based on really very recent data that's been coming out of Europe and South Korea and places in the past couple of weeks. And really the process of refining the estimates in those models has been an ongoing one. So, you know, we can start with broad brush pictures when we don't really know very much. That's where we were at the start of February. We had a growth rate. We had a very, very broad canvas of thinking about the severity of this disease. And so those estimates of severity have got better over time, but we still don't know them in our context. And that will be really important in thinking about the likely impact on the health sector as we understand the progression to the need for clinical care in our setting. So that's one piece of one type of information, one type of evidence that we'll need to understand how healthcare utilisation in Australia will look. And then, sorry, I've missed a bit of your other question. So that was about the modelling and how long it's been provided. It's been being refined and it's being used to develop that strategy, and it's now at a fairly, you know, coherent phase where we see these multiple measures together. I'm sorry, I've forgotten the other part of your question.
I'm happy to.
The question was what date was it provided to the government, and then what's the next big change that you?
Big change, yeah.
So I think we've covered the date. It was early in February. The next big change, I think, is a really important question. Well, there's two parts to this. The first one is moving to this data-driven short-term projection, which we've already talked about. But the next really big thing, and this is a global issue, not an Australian issue, is where do we go from here? So some 6 weeks ago, there was a lot of talk about a 2-week or a 4-week lockdown, which was not really, from my sort of view, it wasn't a particularly realistic idea about where what would that do? It would delay everything by a little bit, but it wouldn't help us actually respond in the long term. We've now got to, I think, a critically important state in our society where we are suppressing the infection and keeping our hospital system under control. But we can't stay like this forever. I think it's clear. I mean, this is a very strange way of holding a press conference, and it's a very strange way of living at the moment. And the whole world is wondering exactly where this goes. And so the next big question is that global question. Even if we eradicate the disease in any given country, if we manage to in Australia, which may or may not be likely, but even if we did, we know that there's an epidemic spreading around the world, and that epidemic will, in some places, may also go locally extinct after a small or a large wave. But it's almost implausible to imagine this virus going extinct globally, which means that it will be here to stay. It will become a part of our everyday life, and the transition to it not being a huge driver of complete societal change is a very difficult thing to work through. We can see this if we look back to 1918. We've all heard about the 1918-19 influenza pandemic, and over a period of 9 months, there were 3 massive waves of infection that caused a lot of death. What's less thought about is that for the next 5 or 6 years, there were elevated levels of disease activity from that same virus as it settled down to become a part of our ecosystem, so to speak. And then it was there for decades afterwards, continuing to mutate and change, but fundamentally the same virus. And so that's the real question to me. It's a far harder question to think about. It puts all sorts of challenges towards society, which is how do we transition to a world where that virus is part of our everyday health and sort of life. And no one really knows what that looks like from our side of things, being the global modelling community. And more broadly, no one really knows how to go through that transition socially, ethically, economically. Luckily in Australia, we can talk about that from a position of calm, not crisis, as I said in my introductory statement. So there's no answers there, but there's lots of people talking about it, including the G08. Thanks.
Okay. So we've just got a couple of questions left. It is 4 o'clock, but if we can just have 5 more minutes of your time, that'd be great. Smriti, you have a question?
Hello.
Sorry, Smriti, we can't hear you. You'll have to start again.
Hello, can you hear me?
Not well at all.
Oh.
Sorry, Smriti. If you're able to send me an email with your question and we've still got time, we might be able to come to it. But at this time, we can't actually hear you. I'm sorry. Penny Durham.
Hi, can you hear me?
Yes, we can.
Right, quick one. So the PM and the CMO alluded to modelling that would now be done that involved Australian case data and Australian scenarios. Can you tell us, first of all, just to be annoying, a time frame on when that will be released? And more interestingly, what specific questions will that modelling be trying to answer?
I think that's one for me. That work has already begun, and differently to the first work, this is like, it's a little bit like weather forecasting, what we're talking about now. So we will, every day the data updates and then you make a new short-term projection. That's what a weather forecast is. It's mathematical models applied from physics applied to weather climate data. So the analogy here is that the first work we've done is like a climate change, long-term principled sort of what the weather might look like, and the work we're pivoting to is the daily weather forecast, which changes every day. So we're doing that work. We will be updating that, re-examining Australia's data 2 or 3 times a week, possibly every day, depending upon how much change in activity there is, and we will be then providing these short-term forecasts around what we believe the transmission is, what we believe the future load on the health sector will be, and what we believe, how to then respond to that. That work will be updated regularly, as often as it needs to be to make decisions, and then in terms of how the government chooses to report that back at what frequency is a question for them. And so that's how that phase of the work will proceed, and it's already underway literally in the last few days.
Thanks, James. Kirsten Lawson, we're going to give this another go. Kirsten?
Yes, can you hear me now?
We can.
Okay, thank you. Sorry about before. So I'm just trying to marry up the modelling with the slides that have been released by the government, specifically the scenarios 3 and 4, which refer to the state where we get to 100% of people who need hospital ICU beds can access them, which is, looking at that data, it seems to be just under 5,000 beds. I just wonder if you can explain, please, how your work informs that. What are the interventions that get us from scenario 3, where 80% of people who need ICU beds can access them, to scenario 4, where everybody who needs an ICU bed can access it because we're down below 5,000. Was that the aim in your modelling, to sort of present a scenario to the government where they could reach the 5,000 beds, which is what we have, and what did it take to get there?
Yes, so basically the model has the unmitigated scenario, which is 1, and then we add the quarantine and isolation interventions, which is 2. And then we looked at 2 different levels of social distancing impact. And as I say, we're not calling that any particular measure. We're just saying if we have the active case finding ongoing, what additional level of suppression of spread overall overlaid on that would be sufficient to keep us within that health sector capacity. Now, So there are two different levels overlaid. And when we run the model, we don't run it once. We run tens of thousands of simulations each time that reflect a lot of that remaining uncertainty in the clinical demand. And so what we then present are statistics from the model, which say of the required capacity, what proportion of people were able to access that ICU bed capacity. So these are sort of summary statistics that come from these many tens of thousands of simulations. And the purpose of doing the model that way is to say uncertainty exists, but even given uncertainty, are there still strong qualitative conclusions that we can take away that help to inform an overall approach? And really the strong conclusion of the model is that we need to obviously build sector capacity to a safe level that would still enable high quality care, but also that we need to then be able to titrate these other case targeted measures like quarantine and isolation and the social distancing measures and work out over time how we manage both of those things in our population to keep within that health sector demand. So, you know, it's very artificial to think that we would have the same level of all of those interventions applied over time to a single smooth epidemic course. But these are the tools at our disposal to work out how to titrate, and this is what we're talking about in this future phase. Where is our epidemic going? What are these measures doing? What is our ability to find and isolate cases and quarantine contacts? And how does that play into how our response needs to keep being updated and evolve and change over the next phases of response?
Okay, final two questions. It'll be Tom Burton and then we'll try Smriti again. Tom?
Hi, Tom Burton here. Can you hear me?
We can.
Oh, good. Thank you. Thank you for the question. Tom Burton from the Fin Review. I just want to go back to James's observation that we may have be in the peak or passing through the peak based on the current data. I just want to understand that a little bit better, James, if you could explain that. And then the second observation is, if that's the case, what's our best estimate for if we just let the current settings run under whatever scenarios you've got there, would be the likely time that we'd reach some sort of community infection? Sorry, herd immunity point.
Right. Okay. So the reason, I mean, it is very early days to know exactly what's happening in Australia. What we saw the last few weeks was a huge increase in positive cases through the arrivals, international arrivals, which reflects nothing more and nothing less than exponential growth in epidemic activity overseas. And we've all seen how the government responded to that in what I believe is a successful way to reduce those international arrivals, which clearly every one of them has the potential to further the spread within the Australian community. So that's one part, and the state-of-the-art analysis techniques, including things like methods that you could see available at the London School of Hygiene and Tropical Medicine Coronavirus Response Group. They can account, and we use these, and in fact, contributing back to those techniques. Those methods can decouple the importations from the local transmission and then try and estimate how much activity, how much onward spread there is from people within our community. And the very early signs are that that onwards transmission within the community is also, it's not growing explosively, it's sort of right on the edge of going up or down in terms of how many cases each community case is producing. What is absolutely clear is if we relaxed any of the current measures, that would turn into an explosive outbreak driven by community transmission, and we would be in a very poor situation very quickly. To your other question about if we held on to the measures that we are having at the moment, it's quite uncertain if that epidemic is going up or down, but it's possibly going gently down, which means that we would, if we held it forever, which I've done my scare quotes on the video here, because forever is, I don't even know what that means, but a very, very long time, we would, and there was no air travel, we would drive it away, and the vast majority of Australians would remain fully susceptible to the infection, which is nothing. Herd immunity is a large proportion of people in having either been infected and recovered or vaccinated, and we'd be nowhere near it. Hence the big question about what the globe does as they learn to live with this virus. I hope that answers your question.
Thanks, James. So we'll try again with Smriti there. Are you there?
Hi, can you hear me now?
Yes, we can.
Okay, great. Sorry about that. I was just wondering what some of the distinguishing characteristics were of Australia's system and capacity compared to other countries, and what other countries could potentially learn from the work that you have done here, if anything at all. Thanks.
So I think Australia's response has been marked by being very early and proactive. And I think the underpinning tenets of the various aspects of response there in the public health response, clearly a high testing rate, enhanced public health case finding and quarantine. It's been massive scale up of the workforce involved in those activities over recent weeks and months. And obviously our health sector capacity is very strong, and it's something that's discussed not very much, but it's very clear that the capacities of our health system far exceed that of many countries in our region and around the globe. It's also clear that the social distancing measures that we're imposing are luxuries of a high income country, where we can actually have people who stay at home and don't work and can still eat. And there's a lot of people in this country who are experiencing financial hardship because of those measures, but in many parts of the world, they're just not even conceivable. And so I think, globally, we are in a very fortunate position to be in a state where we've been able to control this virus, where we can stop and think and learn from the experience of countries around us who are ahead of us on this journey, to try to understand best how to navigate a pathway through. But for many countries, those things simply aren't options. And so I think we also have a really strong responsibility to try to do what we can to support our global neighbours.
Thanks, Jodie. Now we're going to need to wrap it up there. We've already gone a little bit over time. James and Jodie, thank you very much. Do you have any concluding remarks?
I'd just like to say one little tiny addition to Jodie's answer there about what perhaps other countries could learn or take. One thing is that the work we've been able to do has been built on a very long period of collaborative engagement with the Department of Health and the Commonwealth, and I think that's actually really served us well. As as Jodie said at the opening address, we put some kind of scary numbers about what we might be faced with to the government early on, and it wasn't dismissed. And that only happens in an environment where there's long working relationships that are sometimes complicated. We're independent academic scientists, and we've got our own priorities and initiatives, but then we also have that working relationship with government. So the trust there is something that served us and our community well, and I think so that's something sort of, I think, very positive to take away from this in response to the final question. Thanks.
All right, so the two modelling papers that the Chief Medical Officer Brendan Murphy alluded to in his press conference earlier are now on the Doherty Institute website. You can access them on our homepage. This press conference will also be available through our website as soon as possible, barring any technical hitches that we will come across. But thank you very much for your time, and yes, we'll see you all soon, I'm sure.
Thank you.
Thank you.